Just going to go over some procedures, the common elbow procedures, really for tennis elbow, maybe a little bit of golfer's elbow, and elbow aspiration. Pretty quick bunch of cases, and then we'll break. Okay. So it's interesting that you mentioned that cortisone doesn't really ultimately help people, and I agree with that. I don't think I think it does in the short term, and I think cortisone can be a little bit of a wild card. Sometimes it really does knock it out and it just doesn't come back. Like sometimes I'll even see that for the shoulder, for impingement. We do a subacromial injection of cortisone and they're great for like a year or 2 or 3, and then they don't ever come back. And so that's kind of hard to argue against. And I think sometimes with tendons, with elbow, any kind of tendinosis, sometimes it could actually be very effective for a long period of time. But generally speaking, I agree. Like cortisone is really not the way to go. So this was a patient that I saw. It's actually both cases are the same patient. I first saw him tennis elbow. So what I did essentially was an elbow fenestration. I'm sorry that the screen is narrow. This was unfortunately the way I recorded it originally, but here we're just going with some of the anatomy. You can kind of see most of the problems with tennis elbow involve the extensor carpi radialis brevis, which is really the most lateral tendon that attaches to the lateral epicondyle. And then when I go in and I do a tendon fenestration, my orientation of the procedure is usually good, is almost basically always going from a distal to proximal. So I wouldn't go this way because you got bony landmarks in the way, you got the lateral epicondyle out the way. But whenever I'm doing a fenestration, it's good to turn your probe like you just saw. The probe is now translucent, but just to know where you are in the tendon from a medial lateral view. If you just fenestrate the tendon with the probe, let's go back. If you just fenestrate with your probe in that position, you may just wind up fenestrating the same part of the tendon over and over again, and it's not what you want to do. You want to cover as much ground as you can, or at least fenestrate the part of the tendon that you think is most affected. So here's a case where we'll just kind of run through this quickly. So he was a patient with tennis elbow symptoms, and I said I think PRP is the best, but he didn't want to pay for PRP. So I said maybe we could just try fenestrating the tendon, injecting some saline. So here's this tendon with this dark zone of tendinosis, some partial tearing. Also, there's a little bit of hyperechoic, like punctate hyperechoic signal consistent with calcification. Here's the lateral epicondyle. Here's the tendon. A little bit of calcification there. And here you can see essentially, all this tendinosis and some intrasubstance tearing. You may want to be a little bit ginger the way you communicate to patients, about tendinosis, because there usually is some intrasubstance tearing, but you don't want to freak them out and think, make them think they have this like horrible tear in their tendon. You can just say part of irritation of the tendon involves these little small intrasubstance tears, which usually don't amount to a whole lot. It's just usually part of the process. One thing that's pretty funny here is that if you look, the probe looks like a little bit of a turkey neck. You see there's like a glove on the probe. That's because we ran out of probe covers. So at least I covered it with a glove. I mean, that's if you can't afford, or no, not if you can't afford, if you just don't have on hand the probe cover. I make sure to cover it with something, but this is a very sloppy way of doing it, and it's definitely not ideal. But I've done that multiple times when there were no probe covers. At least I do that. And you'd see some other people, they use like almost like a tegaderm, like it just covers the actual head of the ultrasound probe, which I think is okay, but I don't think it's nearly as good as covering like the probe, the wire, because when you do a procedure, you don't want to, you can get blood on your glove, hold the wire, and blood on the wire. Like it's just better to cover everything. So here we are. This is our needle. It looks like a 22 gauge needle going in from a distal to proximal view. Here's some iodine on the skin. It's not blood, at least not yet. And here's my needle, and I'm just essentially fenestrating and going right towards the lateral epicondyle. I'm trying to break up this little calcium here. I don't barbotage these or anything, so you're not going to get anything out of it. And looks like now I'm switching to a out of plane approach. So whenever you do something out of plane, you're just going to see like a little bright dot go in and out of view. And the way that you know it's the tip is that it goes in and out of view. If you just see a bright dot that doesn't go away, then you're probably looking at the needle shaft. So once you see this tip go in and out of view, then you know you're looking at the needle. And here we are just going in some more. It looks like I already injected some saline. So I really just fenestrated the tendon. I inject some saline. And there are some theories that it's almost like a prolotherapy approach in a way. I think distending tendon fiber somehow is therapeutic. And I think the saline may help spread the blood around and may help it heal. But turned out this didn't really help him a whole lot. so we tried. He came back probably maybe like a month later. Still, I think he was pretty sore, which is to be expected. He was sore for like a good week or two because we did, kind of tenderize his tendon, and it didn't really work for him. And I would probably do something similar with PRP, just do the PRP after. I think that would have really helped him. So I said, I gave it, I think this was like a good month or so afterwards. I wouldn't do cortisone right after fenestrating the tendon like that because you probably weaken the tendon to a degree. So here's another view. This is a little bit bigger and nicer to see. So here again, here are the tendons. This is the saline or cortisone mixed with saline, just going right on top of the tendon. So like Dr. Jacobson said, you don't want to actually inject the tendon intrasubstance-wise. You want to actually inject the, you just want to kind of bathe the superficial aspect of the tendon in cortisone. You're kind of like hedging your bet. So here's my needle. This is this whole hypoechoic tendon. Still had that little calcium spot, so I guess I didn't really get rid of that. But this whole red zone is the hypoechoic tendinotic part of the tendon. And here's my needle going right above it. Not a great video of the procedure. I guess the way my camera was, it was like blocking. But here we are. We're just injecting saline and tendon. And as I inject, I can actually move the needle further proximally just to get right over that lateral epicondyle tip. And one piece of advice for the other procedure, when you're fenestrating the tendon or doing PRP, there are some people that actually try to tickle the bone a little bit, maybe stimulate that periosteum, may elicit some healing factors. And it is, it could be painful, but usually it doesn't. I don't know, people don't jump when if you very gently tickle the bone a little bit. If you ram it, I think it will hurt, but if you just gently nudge it a little, I don't think I haven't had many people complain. But here we are, we're just injecting basically the superficial aspect of that common extensor. Here's the lateral epicondyle, here's the needle tip right at that, origin of the common extensor tendon, and then we're just bathing everything. And actually that did help him a lot, so I don't know. I haven't seen him since though. I saw him once for a follow-up a couple weeks later and he was very happy, but this is already months after this, so I don't know how he's doing right now. And there's some thought that if you do cortisone, then let's say you want to do PRP afterwards, the chances of the PRP working as well are probably less, after the cortisone injection, because they kind of work in opposite directions in a way. So, but be it as may, that was that case. Unfortunately, that's the world we live in. We have to lay out the options for patients. Lay out the risks, what may or may not happen, and then ultimately it's up to the patient to decide. Again, they don't have to pay for that procedure, so that's a big factor as well. So here's a case of PRP, really similar approach. So we're going from distal to proximal. Here's some calcification. Here's a pretty large intrasubstance tear. It almost seems like it's delineating that tissue plane between the radial caudal ligament and the common extensor tendon, which is pretty boggy here, hypoechoic. You lose that fibular texture, so that's pretty indicative of tendinosis. And he was manual labor. I think he's had this for quite some time. And then, here it is. Basically, this isn't short access to the tendon. So he had this common extensor tendon tear, a little bit more of the tendon. And then we just basically, here's our platelet-rich plasma. So this is using the Harvest system. Harvest system is white cell rich, and it also has more red cells, I think, than most systems, which for joints, probably not the best thing, but you could give it an extra spin for like 4 minutes and get rid of like 90 or 95% of the red cells. But for tendons, I think it actually is fine. I think for tendon injuries, it's actually discussed that it's better to have a white cell rich concoction of PRP, and I think the red cells do add actually to healing even for tendon problems. So here again, I'm trying to break up this calcium with the needle tip. I'm using a 22 gauge needle, and he already has a pretty large intrasubstance tear, so I don't think his injection will be as painful as, let's say, injecting a solid tendon, because the injectate has space to travel. So I'm doing my fenestration, and the fenestration is not terribly painful to the patient. As long as you, again, don't ram it into the epicondyle, it should be fine. Here's the PRP. You can see how it's spreading nicely. All this white, this air within the PRP, it's spreading nicely within the tendon, because again, there is intrasubstance tearing. And that was essentially it for him. I think I saw him back, let's see.
We took care of it. And you had that problem, since January 2014, we did the shot in May. And then when did it get better? It was sometime in June or July? Somewhere around there. And how's it?
So he's very easygoing, but it helped. So it took about a good month, maybe a month or two, but he had this chronic issue, and it just basically went away. I don't think I have to, this is kind of a model similar to what we talked about, so maybe we'll just go over some anatomy again, just to kind of review. So, just focusing on the elbow. So this is the confluence of all those extensor muscles. Here we are removing the muscles. Again, I don't want to get into anatomy because this is a little bit too much overlap, but essentially this procedure, we just go from a distal to proximal approach. Here's some swelling of the tendons. So this is tendinosis, mostly involving extensor carpi radialis brevis. And then we just fenestrate it, try to cover basically this whole area of the tendon. Whenever you change directions, you got to almost pull the needle completely out, reangulate, and then either you go anterior, posterior, medial, lateral, whichever way you're going, but you have to make sure to actually pull out your needle. Okay, I'm not going to go over this, but this is basically MRI findings, and Dr. Jacobson went over that. And then I'll maybe just run through real quick. It's really essentially the same as tennis elbow. I mean, it's essentially the same. Instead of the radial collateral ligament, you have your ulnar collateral ligament underneath that. This was a semi-pro football player. This was very early in my career. I was very excited about this case. So we did the PRP, and here's his medial epicondyle. You don't see it so well. Again, I was just starting off, I guess, but this is this kind of hypoechoic, kind of non-fibrillar tendon of the common flexor tendon, and then we just injected the PRP into that. You always want to inject where the patient's tender, and one of the nice things about PRP, like we were saying, is that there's a certain buffer zone. Like if you don't get it exactly where you have to be, but it's kind of close and it travels, it will help the patient. Cortisone, you want to be more careful. You don't want to inject the tendon itself. You want to make sure you're superficial to the tendon. But PRP, it's good to inject the tendon, even though it hurts. Certainly you want to bathe the tendon. And usually, whenever I do a PRP injection, I usually save the intratendinous part of the injection for last. Save the best for last, because that's the part that really hurts. So you don't want to do that first when they say, that's it, I gotta stop, we gotta stop. You don't want that when your procedure starts. You want to do the least painful part of the procedure first. I'm going to finish up here with a elbow joint aspiration. So here's a patient, you can see him right here, that came in basically with an elbow effusion. You can see the sale sign here, with the fat pit, anterior and posterior fat pit signs. This fluid basically pushing up the fat pit. All right. So this turned out to be like a gouty effusion. Here's a fat pit in the coronoid fossa. Here's the capsule. Here's your capitome, your trochlea. Here's the joint now flexed. Here's the capsule. So the way that we do this procedure is essentially we just go in. This is an in-plane approach. Other approaches, you can go in-plane approach, but you can go lateral. You can go on the lateral epicondyle and go in medially. But here I went from basically a proximal to distal approach. And then I injected with cortisone afterward. I was pretty convinced this was not an infected joint. I thought it was essentially a gouty olecranon bursitis. So here's all this fluid within the olecranon recess or posterior recess. Here's the fat pad that's being pushed up, triceps tendon. Here it is. Now this is actually not the triceps. This is actually the radiocapitellar joint. There's all this like urate crystal icing or kind of double contour sign from gout. So that was another very good clue that this was all like a gouty effusion. Here's the big tophus that looks like just under the common extensor tendon, kind of taking up the radial collateral ligament. So, it did not look infected. He didn't have a fever. There was no like redness. Even though gout can look like an infected joint, for him, it did not, appear to have any kind of infection. So, where are we now? So now I'm going to just skip ahead and just go down to the back of the joint. Here's this looks like the annular ligament over here. Looks like there was a little bit of uric icing of that ligament as well. So again, let's just orientate ourselves. So elbow, hand, the arm, the shoulders up here. So we're going from a proximal to distal approach. So you have to go through the triceps tendon. So I went through triceps tendon, muscle, this is probably some of the medial head. Here's the fat pad that I have to go through. And then I try to get my needle all the way down into basically the bottom of this cave where there's just, this anechoic fluid. And then we got basically, like maybe 10 cc's. Here's my cortisone. And then I just injected, and that really took care of it. We sent it out, and it basically showed, uric crystals or gout, or pseudo gout. So I think it was more gout, but and that was it. I mean, I kind of like that approach. Another approach that you can do with the elbow, which I don't have here, but you could, if we just stop it, you can essentially go. Let's say this is lateral. I can't tell here because here it looks like there's here's the radial head. You could just go this way with your needle. So your probe will be in an axial plane, and then you just basically go in from lateral to medial with your needle. So you're an in-plane approach, but you're kind of doing cross-sectional view of this olecranon recess or fossa. And that's it for elbow. Does anyone have any questions?
Doing the needle penetration for either golfer, tender's elbow, or however you want to call it, tendinosis. What kind of gauge needle are you using, and how many times are you passing it through?
I mean, I don't really count how many times I pass it. I usually like to use a 22 gauge needle. I mean, really, I think in the literature they talk about using a larger needle, like at least a 20 gauge needle. I wouldn't go larger than that, but how many times do I actually fenestrate? I guess for how long? I usually do for a couple of minutes, a good 3, 4, 5 minutes. I try to go, different parts of the tendon with the needle. I would probably say at least 20, 30 times, like I'm going in and out of the tendon just to really make it bleed.
Texture change, right? You're feeling for change in the texture? Is that your tangible endpoint?
It's not really changing the texture. I mean, I just see where the problem is and where the tendon, what I see is abnormal in ultrasound, and then I'll just fenestrate that part. But I'll try to get the whole tendon. But it's probably like 20, 30 times. I don't know if Dr. Jacobson, usually it takes like 3, 4, 5 minutes for me to do that.
And you can call me John, by the way.
Okay.
Anyway, so 20, 30, I do that as well. I don't count. Covering the territory that's abnormal, as you said, but it does start to feel soft, a little bit more like tomato paste. But the main thing is to make sure you cover the area that looks bad in the cone shape, up and down, and whatever. I do exactly.
Right. So, and I don't usually, it's interesting, I don't usually use lidocaine for it, but I think people can tolerate it without it. Now, you could use lidocaine for it. I mean, for it, if you think, you could do a better fenestration with the lidocaine, that may outweigh the risk, because, it could inhibit fibroblasts and collagen breakdown, but I don't know how real practically that is a problem, but if, you think the lidocaine would help you do a better fenestration, the patient will like you better, then that's certainly a good reason to use it. Yeah?
Yeah, so this is probably the most common fenestration I have done. And I put a thin layer of lidocaine over the tendon. So I have the lidocaine loaded up, and I go down to the surface, I put a little bit of lido, just a little like 0.0, I don't even count, just a little bit. And I found that after I do that, they feel no pain at all.
Right.
That's where the nerve endings come in. When I'm fenestrating the gluteal tendon to the greater trove, some of them can be very painful. But I'll still put lidocaine over the tendon just a little bit, and I recognize exactly what you said, that it could theoretically change the pH. That's probably more theoretical, but I would say that in the greater trove area, that's one area where I'm fenestrating. Sometimes I have to give more than a little puff of lidocaine, even in the tendon, which I don't like to do, but when they're
painful, yeah.
Something.
So again, right, it's a judgment call, but if you think again you can do a better job, and I'm a little tougher on patients than John, I guess, but so that's elbow. So let's take a break.